evening, Dr. Samer. يا هلا مرحبا.
أهلا وسهلا. هلا. Good
يا
evening.
هلا يا هلا. Okay, so we are starting soon. So I just was asking the audience. Yeah, we'll start in a minute, Dr. Samer.
Yeah, okay, that's fine. I don't know if can you see my screen here?
Yeah, it is very good. We
Okay.
very clear. We can see it, and yep. So just in case we don't want to start before people catch up with the last minute. So just we have the chat. You can put down any comments, any questions, anything you want to contribute with. You can write your questions from the start because the questions will be at the end. And but again, any suggestions to do with topics, with subjects, with whatever you would like to hear in the next CME programs, let us know. Okay, so I think we are nearly there.
I've got a suggestion not to have it on Friday. Friday is a difficult time. I had to leave my visitors. Although it is Corona, we have still some visitors home.
Yes. Yeah. I mean, saying that, Hannah and the organizing team, they conducted like a questionnaire, and they tried to find out what is the best day and time of the week. And because we thought Friday is a family day, and why we spoil evenings and so on. But surprisingly, Thursday evening and Friday evening were the best days and times. Again, anyway, I think probably now with the DOH sort of new decision about resuming CME activities, we will check. Probably it's going to be one of the weekdays, evenings. So, and hopefully it will be not the Zoom basis, will be sort of meetings in a hotel or something, but certainly will keep you informed about any change. Okay, well, I think it's time to start. Yeah, okay, thank you, Tindy. Could you please mention your name and email for the certificate? Yeah, I think this is you can see the message from Hannah. She says that all attendees, please put down your names and your emails so that we can send you the certificates of attendance and your CME certificates. Okay, well, let us start. This is a good evening, everybody. This is another CME Mediclinic activity. It is a joint Mediclinic for Al Ain region, Jawhara Hospital, main hospital, and all the medical centers. So it is a joint effort, joint activity, and as you can see, the speakers are from all the Mediclinic healthcare facilities. So we have two speakers tonight, and very interesting topics. The first speaker is Dr. Samer Al-Asli. He is a consultant gastroenterologist at Mediclinic Al Jawhara Hospital, and he is going to talk to us first about the percutaneous endoscopic gastrostomy. This is obviously a very practical subject. I'm sure it is of importance to all doctors, especially surgeons, gastroenterologists, physicians, long-term care facilities, everybody who is really dealing with patients. The second speaker is Dr. Madhavan Makonda. He is a specialist gastroenterologist at Mediclinic Al Ain Hospital, and he is going to talk to us about ERCP in extrahepatic biliary obstruction. So 2 speakers, and then after that they will have an open session to questions for both lectures. And that lecture, obviously, and the question session will be moderated by Dr. Abdul Qadir Badr, and he is the pediatrician and medical director for Jawhara Hospital. So let us start. Dr. Samir, would you please start your lecture? Thank you very much.
Good evening, everybody. So my topic will be the percutaneous endoscopic gastrostomy. It is a review, and I have made it like very simple and easy for everybody to understand it, because I understood that not only doctors, might be also some nurses, or not only gastroenterologists, of course, attending this lecture or this meeting. So as outlines, I'll be speaking about as introduction at the beginning, the indications, contraindications, preparation before the procedure, methods of PEG tube insertion, possible complications, and the stomach care afterwards. So it is a mini invasive method for inserting a feeding tube directly to the stomach through the abdominal wall. It was introduced to clinical practice first time on 1980 using endoscopy. Before that, it was inserted by a surgeon by doing a small incision on the abdominal wall, getting to the stomach, inserting the tube, suturing that. So this endoscopy was used in 1980 as a guidance by using the light of the scope. We will come to this step by step in the next slides. So it is the method of choice in patients who require long-term enteral nutrition longer than 20 days. So there are some gastrointestinal diseases in which the patient has impaired swallowing, like esophageal tumor stenosis. In these cases, the patient cannot swallow, which can lead to malnutrition. Every situation which has swallowing problems or can affect the swallowing or the nutrition is an indication for inserting PEG tube. Neurological, for example, stroke with dysphagia, amyotrophic lateral sclerosis, brain tumors, dementia, Alzheimer, comatose patients, cerebral palsy, with regardless to the age. Of course, patients who are bedridden, who has like recurrent repeated aspiration pneumonia, are also indicated for that. Fractures of maxilla or mandible, trauma to the head and neck, oral surgery, all this is affecting the swallowing and feeding, and they are indicated for PEG tube insertion. Tumors of larynx and pharynx, tongue with invasion to the oropharyngeal area or to the esophagus or preventing swallowing are also another indications. Cachexia, malnutrition secondary to any malignant disease is also an indication. Mental anorexia is a relative indication in severe cases. Patients in critical care unit or in critical conditions are also indicated. Some other indications like decompressing the dilated stomach in obstructive GI tract. I have never done this before, but it is still an indication. Fixating stomach in children to prevent volvulus or recurrent volvulus. Other rare indications, hyperemesis gravidarum with secondary malnutrition, which I do not really encourage, but it is a rare indication. If it is really very, very severe, we can do it. There are some absolute contraindications, which is every contraindication to the procedure of endoscopy itself. If there is a doubt of perforation, or there is a real perforation in esophagus or stomach, so it is a contraindication. Pharyngeal or esophageal obstruction. We have mentioned that if there is a tumor in the esophagus causing stenosis, this is an indication, but if it is causing obstruction, the scope cannot pass down to the stomach. In this case, it is a contraindication, we cannot do it. the unpresence of clear transillumination. I will stop a little bit at this point. As I mentioned, that the scope or using the scopy for as a guide for inserting the PIC tube is done by the transillumination actually. So we inflate the stomach with air and we look for the best place with transillumination. What does it mean? The scope has a light. This light will be seen clearly on the skin of the abdomen of the patient. And this will direct us for the best point to insert or to puncture the abdominal wall reaching to the stomach. So if it is unclear, we cannot find where is the stomach for any reason, it is a contraindication. Because if you will use or you will puncture the abdominal wall blindly, you might penetrate an organ, you can cause a trouble. You can go, you can perforate, for example, the colon, or if there is, let's say there is a splenomegaly or hepatomegaly, you can puncture the spleen or the liver, and you can cause a big trouble. Peritonitis, it can spread the infection. Peritoneal carcinomatosis also can spread the tumor, so it is a contraindication. If there is ascites, you need to treat the ascites first, otherwise all the peritoneal fluid will, or the ascitic fluid, sorry, will be drained through this puncture which you have did, and the healing will be very bad. If there is a severe coagulopathy, INR is high, or there is thrombocytopenia, you cannot do the incision, or if the patient has a long bleeding time due to the use of aspirin or anti-aggregants for a long time. So this patient is contraindicated for the procedure, let's say temporarily, and then can be, if it is possible to adjust it, we can adjust it first and go for the procedure. If there's a gastric tumor, there is no use for the PIC tube because this will spread the tumor and it is not going to help. There are some relative contraindications. If there is pharyngeal and esophageal cancer, as I have mentioned, that if it is causing just a stenosis, we can still do the procedure. But if it is causing an obstruction, we cannot pass the scope down to the stomach, so it is not possible. If there is a previous surgery in the upper abdomen, so mainly to the stomach or sometimes to the colon, in this case, the stomach size will be very small. Finding the good place to penetrate or to puncture is difficult. Sometimes there are some adhesions and some anatomical changes after a surgery to the upper abdomen. So makes the transillumination difficult and possibility of complication or penetrating other organs more frequent. A previous resection of the stomach, this is included in the previous surgery. If there is a gastric ulcer, usually we do our puncture for the PIC tube on the anterior wall of the stomach. So if the ulcer is in the duodenum, or if it is on the posterior wall of the stomach, it doesn't matter really. Usually we prefer that it will heal first, but if it is on the anterior wall, so this will be like possible of bigger complication later, and the healing might be like really difficult. If there is ventral abdominal hernia, this is like, it is logic, we cannot go through the hernia, otherwise it will get worse. Abdominal wounds with infection also is a contraindication. Hepatomegaly or splenomegaly, if they are like big ones, there is a possibility to puncture them by mistake and to cause a big bleeding. Patients with portal hypertension might have, or usually they do have, a liver disease with coagulopathy, and possibility of bleeding is really high, and the ascites usually is associated with that. So those patients have relative contraindications, and every case should be like individually evaluated. If there are gastric varices, the possibility of bleeding is really high. Usually the gastric varices are in the upper part of the stomach. So that's why it is like a relative contraindication. Patients with peritoneal dialysis and recent myocardial infarction, they are usually also on coagulopathy, or they have a coagulopathy due to the anti-aggregants or anticoagulant medications which they are using. So it is a relative contraindications and should be evaluated individually. The age of the patient is not a contraindication. Can do it in the elderly and in the also newborns if it is really indicated. Pregnancy is not an, those are also not contraindication. Duodenal ulcers and heartburn or gastroesophageal reflux. So before any procedure, we need to get, of course, the consent form of the patient or his relatives. Coagulation profile should be corrected. We should assess for any comorbidities and to discuss their indications, contraindications, the benefits of that. Patient should be fasting 6 to 8 hours before the procedure. As for gastroscopy, if the patient is on nasogastric tube, so the NG tube should be, feeding should be stopped. If possible, to bath the patient the night before the procedure and shave the hair of the abdomen, it would be really a great thing. Intravenous access and antibiotics should be given 1 hour at least before the procedure, unless the patient is already on antibiotics. We usually give like 1 day before the procedure and a day on the procedure now and 1 day after the procedure, so 3 days. So we've got 2 main methods, the push method and the pull method. The push method, it is as simple as the inserting a Foley catheter, but with the difference that in the Foley catheter, you have already a path to get to the urinary bladder. But in the stomach, to get to the stomach, you don't have this path. So you need to create one. And the endoscopy is used for this reason. So we insert the scope through the stomach, through the esophagus to the stomach. We inflate the stomach with air. So to keep or to attach the abdominal, the anterior wall of the stomach to the abdominal wall. And at that stage, we will check for the transillumination, which is the light through the skin, as in the next picture here. So it is maybe not really clear, maybe down in the lower picture, you can see the light. We switch off the light in the room usually to get to see the best transillumination. And we, by finger, sometimes we push there just to identify the best place for our puncture. And then for the push method, we need to insert or to puncture with 3 needles with anchors, 3 to 4 needles with anchors through the abdominal wall to the stomach. The role of the anchors or the needles with the anchor is to fixate the stomach or the abdominal or the anterior wall of the stomach to the abdominal wall so that it will not flow away. And then we do a small incision on the abdominal wall and insert a needle. We dilate it later. We confirm that we're in the stomach by the scope, and then we dilate that entrance and insert our push method or the feeding tube with internal bumper or internal balloon, and that's it. Which is like we inflate the balloon inside and we keep it on position. The anchors will fall later on. The push method is simple, but it needs like more than 4 punctures to the abdominal wall. 4 punctures or 3 punctures to fixate the stomach, and in the middle we insert the tube. The pull method is a little bit different. It looks sometimes like more complicated, but it is with 1 puncture only, which I prefer and which we are using here. Actually, this is what we are practicing more frequent here. So the idea of the pull method, the same at the beginning. The scope is in the stomach, transilluminate, we identify the place, and at this stage, we puncture with a needle. Here we can see the set. we puncture the abdominal wall with a needle, and we confirm the positioning by the scope that we are in the correct place. Then we remove this needle, and there is a catheter, or we insert the thread through the tunnel or through this tube which is inserted. The scope at this stage, by the scope, we will capture the thread and pull it outside with pulling that's why it is called pull. So we will pull the thread. At this stage, we will have like a thread passing from the mouth through the stomach through the abdominal wall outside. Then we connect from outside the tube, the PEG tube, which we want to insert by a special technique, and we start pulling again from the abdominal wall. At this stage now, there's here near the mouth, we've got the PEG tube, which we need to pull, and we start to pull it from the abdomen until the tube will reach to the abdominal, to the stomach. So it looks like complicated. Yeah, once you see it, maybe you need to see it a few times. The last stage will be, the inside will be like internal disc pumper, and then you fix it from outside with another external pumper, which has also a tubing clump. So yeah, on the externally, this is what you see here. The Mickey type is the one with push type. This is another picture here, lower part, and here is the classical one with the external or the pull method. Here, this is internal view when you have a balloon, and here when you have the internal disc. This is old one. Here's another picture as internal view. Okay, so as you see that some of them they have like balloons, some of them like they have a disc, internal disc. In the pull method, you put only you will have always a disc, internal disc at the beginning, first insertion. If you want to change it later, you can change it with a balloon, but the first one will be always with internal disc. But the push method, you can put a balloon from the beginning. So it has advantages. Every method has advantages and disadvantages. Some of them like easier, some of them like more difficult. We'll proceed. So possible complications, there are mild complications without mortality usually. The procedure itself, 4 to 33% without mortality. The severe ones are 0 to 17%. With increased length of stay, might need surgical intervention, which can be sometimes lethally. Mortality 0.5 to 5%. The complications could be related to the endoscopy itself or related to the procedure of PEG tube insertion or related to the after PEG tube insertion. So the complications related to the endoscopy itself could be like the cardiopulmonary complications, which are related to the sedation itself, analgesia, myocardial infarction, hypotension sometimes, depending on the type of sedation, hypoxia, 7 to 40%, aspiration. Patient usually is on supine position. So if we do like a classical gastroscopy, the patient is on his left side, which prevents the aspiration. But during the PEG tube, the patient is in supine position, which exposes the patient for aspiration. Hemorrhage or bleeding is rare because we are taking our precautions. Risk factors are the coagulopathy, which we have spoken about or discussed. Sorry. Perforation of the esophagus, which is really rare, but it is possible. Anatomic anomalies sometimes, diverticals, strictures, and malignancies can lead sometimes to the perforation. Early recognition of the perforation of the esophagus has a more is advantage with less mortality. Delayed recognition has a higher mortality, reaching up to 50%. Pneumoperitoneum, which is a benign complication, it is self-limited. Of course, we are puncturing the stomach, so some air can escape from the stomach to the peritoneum, but it is very benign, doesn't matter. Colon injury. This is which I have mentioned also, that we need to make sure that the trans-illumination is correct, so that we will not puncture an organ. Sometimes there will be like a displacement of the transverse colon over the anterior wall of the stomach, which can predispose to injury and can need surgery. This sometimes it happens in a different way. This can cause perforation, of course. Sometimes something else can happen, which is gastrocolocutaneous fistula. In this stage of this complication, which is really rare, there's an interposition of the bowel between the anterior wall and the gastric wall. When we puncture the stomach, puncture the abdominal wall, reaching to the stomach, the colon or the bowel is in between. And it is unrecognized or undiagnosed at that stage, as the bowel movement is working properly and there's no signs of leakage, no signs of perforation, but it occurs or it is diagnosed when we change or when we remove the tube. As there's a fistula there, at that stage, we are usually is diagnosed only at exchanging that tube or removing it. At that stage, it will pass away from the place and it is recognized as a perforation of the bowel, and which needs also a surgical intervention. Small bowel injury is also rare, unless there is a previous surgery which can, with adhesions and so on. Liver injury, it is rare, but it is possible. If there is a hepatomegaly, a big liver, needle injury and placement of the inflating tube into the liver can be really a disaster for the patient and for the doctor. Splenic injury also, if there is a splenomegaly, can be fatal, can cause laceration and perforation of the splenic vein also, which is rare. Immediately we can identify sign. I don't know what's wrong here. Somebody is drawing on the picture. I'm not. Okay. Splenic injury can be fatal, we said. Yeah, intraperitoneal and retroperitoneal bleeding is rare, and this is if there is a penetration, deep penetration of the needle into the stomach, or perforating, let's say, through the abdominal wall to the stomach and passing to the posterior wall. And this is really rare. Maybe if the patient is very, very thin and there's no precaution were done. Abdominal wall bleeding, hemorrhage around the stomach, treated by tight compression, usually for 48 hours, and if severe, by electrocoagulation or by stitches. I don't know what happened to my picture here. There are some people, or something happened that it is as somebody has drawn something over the slides. Just happened now. Anyway, so post-PICC insertion complication, a peristomal pain, which is possible and normal, and this is with analgetics. We can control it. Infection and abscess is possible and reduced by the antibiotics from 18% to 3%. Necrotizing fasciitis is rare, treated by surgical debridement if it happens, and antibiotics, of course. Peristomal leakage, reported incidence is 1% to 2%, but in practice it seems to be more. Obstruction of the PICC tube and dislodgement is possible, and in this case we need to change the tube or to reinsert again. Buried bumper syndrome, I'll speak about this alone. The buried bumper syndrome, which is a real complication, a significant one. So here are some pictures for the infected PICC site. You can see the redness here, reddish around the stomy, in the stomy area, and here also you've got also some granule with erythema and reddish site. Buried bumper syndrome. I don't know if you can see this picture properly. I'll try just to magnify it if possible. I don't know. Oh, it's okay. I'll just keep it. So here we can see internal, this is the buried bumper syndrome. Buried bumper syndrome is a real complication. This is when there usually, if there is no proper care of the big tube, mainly in the first few weeks of insertion with the pull method. When we have, like, as we know, there's internal disc. You can see here in this picture, like something, a lesion here you can see in the middle of the picture. And on the back side, there is a disc, which is the big tube. This is internal view of the from the stomach, showing the big tube from inside here. And here we can see a lesion. This lesion is actually another disc, which is buried under the mucosa of the stomach. The stomach is a life organ. Usually, if there is a very tight, if the disc is very tight to the mucosa, to the gastric mucosa, the gastric mucosa will start to grow over the disc, and step by step it will be buried inside the abdominal wall, in the submucosa, which is really a difficult situation, which sometimes need like incision, or sometimes need a surgical intervention to remove it. So here is the buried bumper syndrome, or this is how it looks from inside. So it happens when the internal disc, which is the fixator, is buried into the gastric mucosa and invisible by the endoscopy. It is rare, caused by if the disc is very tightly fixed to the gastric wall, as I mentioned, causing initial ischemic changes, then ulceration, necrosis, then gastric mucosa grow over the disc, leading to its entrapment in the submucosa. This is treated endoscopically, as I mentioned, and surgically. It can be prevented by simple maneuver, which I have trained also our nurses, and usually explain it in every new insertion of the big tube. It is usually we need to release the pressure every 7 days and push the tube inside, move it 180 degrees to the right, 180 degrees to the left, or 360 degrees, and then return it back gently and not very tight to the gastric wall. So this is another picture for the buried bumper syndrome. You can see it is like almost a part of the stomach that is in the submucosa, and it is not working, it is not functioning, it is blocked. The nurse might find that it is not working. She will call the gastroenterologist to check what's going on, and then this has to be removed, whether surgically or by, sometimes we can do some if we have special methods here or special equipments, we can do it also endoscopically. The most dangerous, so we need to care, of course, about the stomy by doing this maneuver, which I have just explained. And the most dangerous period is the first 4 to 6 weeks. It is very important to observe the site of the stomy in the first few days after insertion to check if there is any bleeding or there is any leakage. We need to avoid a tight fixation and to avoid loose fixation. If it is very tight, it can cause buried bumper syndrome. And if it is very loose, it can cause leakage, and the leakage can cause infection. Dressing for the first 3 days, twice daily, then once daily for 3 days, then no need for any kind of dressings. So here I'm explaining also once again, pushing the tube, rotate 360 degrees, pull it back to its position to avoid the leakage. And we need to flush the tube, of course, properly after every feeding to avoid the blockage of the tube itself. If the tube was accidentally removed, and this happens very frequent in the ICU unit or in the long care. So if it is accidentally removed, we need to insert immediately a Foley catheter with maximum of 6 hours before, within maximum of 6 hours. Usually, as I mentioned, the stomach or the gastric mucosa is a very live organ, and the stomy itself closes internally within 4 to 6 hours. So we need to insert a Foley catheter to keep the tunnel which we have created until getting a new tube to insert it at that place. Of course, exchanging depends on the type. So if you can, it is as simple as urinary catheter. Just push it there, inflate the balloon, and that's it. All PEG usually is deflated if there is a balloon fixator. Pulled hardly if the disc, if there's a disc. Sometimes it is another possibility to remove it, or by endoscopy, which we prefer. If you will pull the disc, it is painful sometimes. So we don't even, also it is like a soft disc inside the internal bumper or the internal disc, but we don't prefer to do it. We prefer to go by the endoscope to pull it and to exchange it with the same size if possible. Total removal depends also on the type. Patient can start eating and drinking after 6 to 12 hours after the removal of the tube or the PEG tube, to make sure that it has closed properly. So that's it. Thank you very much. I hope it was useful.
Well, thank you very much, Dr. Samer. Very interesting, very practical, very relevant. And I think this is, I'm sure everybody was following very carefully. As you said, it is very sort of practical and probably relevant to all of the audience. I'm sure this talk have generated a lot of questions from doctors, from nurses, and so on. But we will leave the questions until the end, after Dr. Mukunda gives his talk. And his talk is, as I said earlier, it is about the ERCP. I'm sure it's going to be another interesting one. Dr. Mukunda, please.
Hello.
Hello, yes.
I am unable to share my screen actually. Let me see.
Hannah, can you help Dr. Mukunda?
I'm sharing, so yeah, you can do it now, I think so.
Because you cannot share screen while the other participant is sharing. Let me see, yeah.
Yeah, yep. I think just you need to start from the beginning. Yes, and put it in the PowerPoint.
Yeah.
I think that's okay. I think you are ready to go.
Can you hear me?
Yes, you are clear.
Okay. Pointer. Just a sec, let me get my pointer ready. Just a sec.
Do you need any help, Dr. Mukunda?
Yeah.
You are okay?
Yeah, I'm just getting things ready. Yeah. Can you see the pointer also? Yeah. Good evening, dear colleagues. Thank you for the excellent presentation from Dr. Samar. So I am going for the second topic of the day, that is ERCP in extrahepatic biliary obstruction. I'm Dr. Mukunda and I'm working in Mediclinic Town Center. So we go to the slides. So just the outline of the presentation. I will be talking under three main headings. First is about ERCP, the technique. Then we will see the role of ERCP in extrahepatic biliary obstruction, the benign as well as the malignant conditions. So these are the three broad headings under which I will cover the topic. So coming to what is ERCP? ERCP is the acronym for endoscopic retrograde cholangiopancreatography, which is an endoscopic technique in which a specialized side viewing upper endoscope is guided into the duodenum, allowing for instruments to be passed into the bile and pancreatic ducts. So you reach these ducts and you start the procedure. So right now you can see this is the papilla. From there the action starts. This is the second part of the duodenum. So,
Dr. Mukunda, you need to move the slide because it's still the first slide on.
Okay. Can you see? Is the slide moving?
Still no, still the same slide.
Okay. Is it moving?
No. Who's controlling the slides?
No, I am actually.
But it doesn't seem to be. Hannah, I think she has copy of the slides. Maybe she can help you with the presentation. Just ask for next slide and she will move it on. Hannah?
I'm afraid I don't have them right now, doctor. It's
Just
on
a
the desk.
second. Slide movie.
Well, maybe you can have it in your email.
Let me see. Is it moving?
No.
Actually, on my screen, I can see them moving, but I don't know.
Yes, now. Yes, now you
It's
can.
moving?
Can you go back to the first slide and then
Is
start
it moving?
moving?
Is it,
Yeah, just go back to the first slide if you can.
it's moving, right? Okay.
Yes, just go back to the first slide.
Yeah.
Yes. Yeah, you are okay.
Okay. So coming to what is ERCP? ERCP stands for endoscopic retrograde cholangiopancreatography, which is an endoscopic technique in which a specialized side viewing scope is guided into the duodenum, allowing for instruments to be passed into the bile and pancreatic ducts to do the necessary interventions. So, is the slide moving?
Yes.
Yeah, so this is the second part of the duodenum. This is the papilla or the ampulla, which is the gateway to the bile duct and the pancreatic duct. And from here we insert the instruments and do our procedures. So before I get into that, I just want everyone to have a look at this slide to just revise the biliary anatomy. So we have the main two ducts actually. The left ductal system and the right ductal system. They come together to form the common hepatic duct. It is joined by the cystic duct which comes from the gallbladder. The common hepatic duct and the cystic duct join together to form the common bile duct, and they finally open out after joining with the pancreatic duct to form the common channel into the duodenum in the form of the ampulla. So this is the opening, and this in this diagram you can see this is that point which I am referring to. So from here we enter our instruments inside and do the procedures. So like some pictures of the ampulla, just to endoscopic views of the ampulla. See there you can see the opening there. So this is the ampulla. This is another view, close-up view. So this is the opening actually. Through this we go inside and do our procedures. But now here you can see a stone peeping from the ampulla. So this is a stone stuck at the mouth of the ampulla. All the time it's not easy to find the ampulla. Like this is a patient with a diverticulum. Here it took some struggle to find out the ampulla, and finally after some efforts we could find out the ampulla. So we use a variety of accessories during the procedure to maintain access into the bile duct or the pancreatic duct. This is a guide wire actually. This helps us to keep access into the bile duct, and like we railroad everything, all the instruments over this guide wire, and all the time we can maintain access into the bile duct with the help of the guide wire. This is another instrument which is called a sphincterotome, which is used to make the ampulla larger. You cut the ampulla so that the stone can be removed. So the interesting aspect of ERCP is that it involves two images simultaneously. That's why it becomes more of a complex procedure. Actually, the endoscopist, with the help of his technician and his team, has to keep a track of the endoscopic image as well as the fluoroscopic image or the X-ray images. So the X-ray images are got by opacifying the duct with contrast medium injection, which helps in radiologically visualizing the stones or strictures, whatever is happening inside the bile duct. So here you can see this is the fluoroscopic image. Earlier I showed you the endoscopic image. Here you can see the scope. This is my guide wire. Just follow this guide wire, and this is the contrast inside the bile duct. You can make out the outline of the bile duct. This patient had a stone. After gallbladder removal. You can see the post cholecystectomy clip here, and the stone has been cleared and the bile duct is clean now. So the fluoroscopic image has to be seen along with the endoscopic image, and that is how we do the procedure. So it's a relatively complex endoscopic procedure since it requires specialized equipment and a long learning curve to develop proficiency. Its benefits in minimally invasive management of biliary and pancreatic disorders are challenged by a higher potential for serious complications than any other standard endoscopic procedure. So what are the complications you face actually? The complications are in the form of bleeding, perforation, and pancreatitis. Pancreatitis is one of the major complications, and it can be seen in about 5% of the cases. So now, I will come to the role of the ERCP in benign extrahepatic obstructive conditions. So this I can divide into mainly choledocholiithiasis, which is the commonest thing, that is stones in the bile duct. Second is benign biliary strictures. Third is extrinsic compression of the common bile duct. And finally, I will just speak a few words about post-surgical complications leading to strictures. So role of ERCP in bile duct stones. So now there has been a paradigm shift in the role of ERCP. Earlier, ERCP was used as a diagnostic procedure as well. Now, with the arrival of MRCP, which is done by our radiology colleagues, the role of ERCP as a diagnostic tool has shrunken really. So we don't use ERCP as a diagnostic tool. So ERCP, MRCP along with endoscopic ultrasound have comparable sensitivity for picking up bile duct stones. And routinely for any patient who comes with acute calculous cholecystitis, you don't require a ERCP unless you have a strong doubt for stone in the bile duct, in which case you go for an MRCP, confirm, and then do a ERCP, depending on the clinical scenario. And in case ERCP is not available, the other option is laparoscopic common bile duct exploration, which is safe and reliable. But now in most centers, people prefer to do ERCP rather than go for laparoscopic bile duct exploration. So we will just to illustrate the points, I will just give you a case scenario. So this is about a 28-year-old Filipino lady who is a lactating mother, delivery 5 months back, presented to the ER with complaints of abdominal pain, increasing jaundice and fever with chills for 2 days. So she has the triad of fever, abdominal pain, and fever with chills, a Charcot's triad. So on clinical examination, the Murphy's was positive. The labs showed high total count with increased polymorphs of 72%. The bilirubin was 2.7 direct total, and direct was increased to 1.9. The SGOT, SGPT were elevated. Alkaline phosphatase was not that much elevated, and the amylase lipase were normal. Ultrasound done showed calculous cholecystitis along with stone in the bile duct, choledocholiithiasis. So in this patient, we don't require to do MRCP because already the ultrasound is showing the bile duct stones. So this patient requires a ERCP, clearing of the bile duct of all the stones and putting in a stent, and then the patient goes to the surgeon for laparoscopic cholecystectomy, and then the patient comes back for removal of the stent post lap chole. So this patient was taken up for a ERCP. So this is the fluoroscopic image. You can see the scope. Here is the guide wire. The cholangiogram has been taken. If you see the cholangiogram, you can see multiple filling defects inside the bile duct. So which is suggestive of multiple stones in the bile duct. So we did ERCP. So this is the sphincterotomy. We are making entries in the size of the duct. Then then we are rolling with the balloon, we are removing the stones, and finally we put in a stent. So finally a stent is placed in place so that the stent stays till the patient comes back after laparoscopic cholecystectomy. So at the end of the procedure, these are the multiple stones in the duodenum. The stent has been placed in, put in place, and the patient is referred to the surgeon for laparoscopic cholecystectomy. So now to summarize everything, this is a short video of about 2.5 minutes where we will just see all the steps of ERCP. So I will just talk to you along the way. So this is my cannula. This is the ampulla. So we are cannulating the bile duct. So you can see here, watch here actually. So my endoscopy technician has put the guide wire inside. We have engaged into the cannula. The guide wire is inside. So once the guide wire goes inside, then we use the contrast and insert contrast into the bile duct and take the fluoroscopic image and see what is happening inside the bile duct. So once we do the imaging, we found stones in this particular patient as filling defects on the fluoroscopy. So next step is we exchange the cannula for the sphincterotome. This is to increase the size of the opening of the ampulla. So with this thing, we create a cut there. So you create a cut slowly. You have to be very careful. This is the place where you can create a complication, a perforation. So usually we give cut in the direction of 11 o'clock position. 11 to 12 o'clock is the direction in which we give cut to increase the size of the sphincter of OD opening. So we cut the sphincter so that the opening gets bigger and the stone can be removed. So this is a balloon catheter. We can use balloon catheters or baskets to retrieve the stones. So what we do is that this is a catheter which has a balloon on its top. So the balloon is taken up. You can see with the balloon, when you pull, you go above the stone, pull it out, then you can pull out the stone. So the stone has been pulled out, and we troll with the catheter inside 2-3 times, and after that we go for putting a stent at the end of the procedure. So this is the stent being placed in. You see that that's the stent we are inserting. So the stent stays in place and drains the bile duct. So you can see it's being deployed, the stent. So the purpose of the stent is to prevent further stones from falling into the gallbladder. Yeah, that stent is now deployed, and after the procedure, the patient will go to the surgeon for laparoscopic cholecystectomy. And after the laparoscopic cholecystectomy, they will come back for the stent removal. So stent is a guarantee against further stones falling into the bile duct. So that was the commonest indication for ERCP, the presence of bile duct stones. Next indication is in its role in biliary strictures, especially in patients with chronic pancreatitis. You get benign biliary strictures. So symptomatic strictures of the bile duct develop in 5 to 10% of the patients with chronic pancreatitis. They develop due to inflammation and fibrosis in the head of the pancreas or compression from a pseudocyst in chronic pancreatitis. If it is compression due to pseudocyst, you can drain the cyst and you don't need to do any ERCP. So how does CBD obstruction happen in chronic pancreatitis? So this is this happens because a part of the biliary duct, that is the distal part of the biliary duct, has an intrapancreatic course. So if there is fibrosis and inflammation in the pancreas in the form of chronic pancreatitis, the intrapancreatic portion of the bile duct gets strictured. And these are tough strictures, and endoscopically, they are a bit difficult to manage. I will come to how we manage these cases. So first are when to treat these strictures. As per the European Society of Gastrointestinal Endoscopy guidelines, they recommend to treat chronic pancreatitis related benign biliary strictures in cases with symptoms. Symptoms means the patient has obstructive jaundice, patient has cholangitis, patient is going for secondary biliary cirrhosis, or there is biliary stones secondary to stasis. So in all these scenarios, you have to treat the patient. Then if the patient is asymptomatic, but there is elevation of serum alkaline phosphatase greater than 2 to 3 times the upper limit of normal, or there is raised serum bilirubin persisting for over a month, then you have to treat these patients because they might be asymptomatic, but they will go for secondary biliary cirrhosis. So that has to be kept in mind because jaundice can have a prolonged and intolerant course, and transaminases may also be elevated, but patient might be asymptomatic. So more than 1 month they remain, the possibility of secondary biliary cirrhosis is there. So if the lab parameters are abnormal, the patient has to be taken for ERCP and dilation of the stricture. So management, you have both operative management and ERCP based management, that is endoscopic management. Operative biliary bypass was the treatment of choice earlier with the choledochoduodenostomy or Roux-en-Y jejunal bypass in patients with bile duct obstruction as a complication of chronic pancreatitis. And as I talked to you earlier, if you have a pseudocyst pressing on the bile duct, then you can just drain that pseudocyst. And if you have a concomitant duodenal obstruction, it may require gastric bypass with gastrojejunostomy, and some require pancreatic preserving pancreatiduodenostomy. So coming to the role of ERCP in benign biliary strictures. So here the stenting is a bit different. Endoscopic stenting is a temporizing measure as it frequently requires several stent changes and placement of multiple stents in the CBD. And if your patient on CT shows pancreatic head calcification, these patients are unlikely to respond to endoscopic intervention. Single plastic stents are associated with poor resolution. So this is a situation where you put multiple stents. The patient has to come back repeatedly. So every 3 months the patient is called. It might take a year for the symptom resolution. So every 3 months you call the patient, you do ERCP, put in a stent, and each time you progressively increase the number of stents you deploy. So ultimately, like after 3-4 sessions, the patient will have multiple stents in place, which will keep the bile duct dilated and may lead to resolution of symptoms in around 90% of the patients. And if it doesn't work, then you have to go for surgery. Then coming to the final indication, that is lap chole injuries. In the earlier phase, when lap chole was coming, there were more cases of bile duct injuries, but now surgeons have sufficient expertise and these are rare phenomenon now. So I will just quickly go through the situation where the lap chole injuries can happen. So just keep in mind the anatomy, the right and left duct join to form the common hepatic duct, cystic duct coming in, joining, forming the CBD, ultimately the PD joining, forming the common duct and draining into the duodenum. So why do these injuries happen? The surgeons face the problem because there is variation in cystic duct anatomy. So, and post cholecystitis, usually the patient have the Callet's triangle where the surgeon works has lot of inflammation. So that's why there is chance of injury. And the anatomy varies from person to person. The cystic duct doesn't have a uniform insertion. So that's the reason for the injuries. Like there is a low cystic duct insertion. Sometimes the cystic duct will be adhered to the common hepatic duct. Sometimes you have a high insertion. So because of these variabilities, it creates problems for the surgeons. So these are the images actually of different types of injuries which can happen. The cystic duct is transected. The minor hepatic duct can get transected. The bile can get leaked. There might be accidental ligation of the duct, which can later on cause secondary cirrhosis. Then the lateral part of the duct can get damaged. These can be managed with ERCP. You put in a stent and you can manage them. And sometimes what happens is that the confluence of the ducts gets damaged. These cannot be managed with ERCP. You require hepaticojejunostomy in these situations. So these are the injuries. I won't go into the detail of these things. These are some images of the different types of injuries. This is, you can see the contrast going in. This is a complete transection of the common bile duct. Above that, you don't see the right and left ductal system. No contrast is going above that. So this is case of complete transection, and these patients will invariably require hepaticojejunostomy for treatment. This is the duct of Lashka leakage. Ducts of Lashka are small ductules found in the gallbladder fossa, and they can sometimes leak, and they usually respond to conservative management, or you put in a stent, and after a while with decompression, the leakage goes away. This is a high-grade cystic duct lump leakage. The gallbladder has been removed. There is some leakage at the cystic duct point, as evident by the contrast here. These leakages can be managed by ERCP. You do a sphincterotomy, you put in a stent, and decompress the system. So the bile flows here, and the cystic duct gets decompressed, and the leak is taken care of. This is another picture showing a high-grade cystic duct leakage. This is like a common hepatic duct stricture. This also, in some experts' hands, sometimes you can manage with dilatation and putting in a stent. So, and this is a complete ligature of the common bile duct. Here, it will be very difficult to manage endoscopically. Mostly, they might require a hepaticojejunostomy. And most of the strictures less than 1 centimeter can be managed endoscopically, but strictures longer than 1 centimeter are more difficult to be managed endoscopically. And leaks can be managed by sphincterotomy with stenting. So those cover the benign conditions. So the benign conditions which I covered were stones in the bile duct, strictures in the bile duct secondary to chronic pancreatitis, and leakage post-surgery. So now I will come to the malignant extrahepatic biliary obstructive conditions. So what are the conditions causing this situation? Foremost is CA head of pancreas. The head of the pancreas, cancer can cause obstruction of the intrapancreatic portion of the bile duct, leading to painless obstructive jaundice with itching, which is a common presentation which most of us have seen in the ER. The next is distal cholangiocarcinoma, and finally the hilar cholangiocarcinoma or the Klaskin's tumor. Then metastasis from CA stomach into the porta hepatis region or other malignancies can also cause extrinsic compression on the bile duct and lead to obstructive jaundice. So what is the role of ERCP in malignant obstruction? ERCP has no therapeutic role in malignant obstruction. The treatment of choice is definitely surgery, but in patients who are non-operable, in these patients their life can be made better. They can have palliation by ERCP. So what is the role of ERCP is doing in this situation? It helps in decreasing jaundice. It improves the quality of life in these patients by reducing itching of the obstructive jaundice by the placement of stents. It reduces the chances of cholangitis by dilating the ductal system. And it is useful in pancreatic cancer, cholangiocarcinoma, including ampullary, distal, and hilar variants of cholangiocarcinoma. So in this situation, mostly we use metal stents instead of plastic stents, because plastic stents will get blocked faster. So you have these dedicated metal stents which stay patent for a longer period of time, and patient can have palliation. So, and finally, coming to the role of biliary strictures. Biliary strictures sometimes are very difficult to really know whether they are benign or malignant. So in these situations, ERCP can help us in taking biopsies and determine the type of stricture, whether it's benign or malignant. But now it has been superseded by EUS and cholangioscopy, which has come into the picture. So the stricture morphology on ERCP is not very reliable in determining the etiology of stricture, although long irregular strictures with shelf-like morphology are considered to be suggestive of malignant biliary obstruction. The presence of strictures in both the CBD and pancreatic duct with proximal dilatation, that is double duct sign, is also highly suggestive of malignant etiology in a patient with jaundice. So when you do ERCP in these strictures, the diagnostic yield of biliary cytology can be increased by using both brushings, for which you have dedicated instruments, and you have small forceps also, with which if you take biopsies, the yield can be increased to 60 to 70%. But I will come to it now, because with the arrival of cholangioscopy, you take cholangioscopy directed biopsies, and it has definitely a better yield than ERCP. And multiple brushings improve the yield of malignancy. And there are molecular techniques like fluorescent in situ hybridization and flow cytometry, which can help in increasing the yield of malignancy in ERCP. So just the use of fish can increase the sensitivity to 84% compared to cytology alone, which is only 22%. Then, yeah, and along with the fish and fish technique, you can use mutation studies from the bile duct aspirate like KRAS mutations and P53, which help in increasing the yield. Then other technology which has come up along with ERCP is what is called a cholangioscopy. Here, through the instrument channel of the ERCP scope, we can, so this is the ERCP scope, and through the instrument channel of the ERCP scope, we can pass a dedicated instrument called a cholangioscope. So if you pass the cholangioscope, you can see the inside of the bile duct. So this has actually revolutionized the diagnosis of biliary strictures. So you can put the scope inside, it's like a baby scope passed through the mother scope, and you can go inside and see the bile duct and take directed biopsies. And it has definitely increased the yield of biliary malignancies. So this is an image of a fluoroscopic image. You see the scope, and this is the smaller scope, the baby scope, with the forceps. And you take the biopsies, and finally you have taken the biopsies and inserted 2 stents to drill the stricture. This is the patient of hilar stricture, and the stent has been placed and biopsies have been obtained. So just an approach to biliary stricture. Jaundice, first test is an abdominal ultrasound. So any patient who comes with a suspected obstructive jaundice to the ER, the first thing you do is to order an ultrasound. So if it's an extrahepatic biliary obstruction, you will get dilated intrahepatic biliary radicals with dilated CBD. If it's an intrahepatic cholecystitis, you don't get the dilated system. So if the suspected obstruction is a proximal obstruction, then you go for MRI with MRCP. If it's a distal obstruction, CT is better. So coming to a distal obstruction, you do a CT. If you find a mass, nowadays you don't go for surgery. You do what is called an endoscopic ultrasound and take FNAC from the mass. If you don't get a mass, then also you can do a US, and maybe from a surrounding lymph node you can get an FNAC. And if you don't see any malignancy, then you do a ERCP and put a stent, and maybe take breast cytology along with that, and put a plastic stent inside. Suppose if the patient is having a proximal obstruction, you go for an MRCP. You can go along with that. The best test will be a ERCP with a single operator cholangioscopy, or the small baby scope, which can be put through the instrument channel, and you can go into the hilum and directly see the mass and take biopsies. If you don't have that available, then you can go for a US guided FNAC from the hilum. But again, US guided biopsies from the hilum are a bit difficult to get. So best test would be a ERCP along with cholangioscopy. And if there is no malignancy, you keep under close observation, and if you get a malignancy, you refer to the surgeon for surgery. So I am coming to the end of the presentation. So I would just like to highlight the main points of the presentation. Take home message is the role of ERCP has definitely shrunk from a diagnostic procedure to mainly a therapeutic procedure. You don't do ERCP nowadays for diagnosing a procedure, diagnosing a problem. For that, you have MRCP and endoscopic ultrasound and CT scan. So ERCP has definite role in the management of obstruction, whether it is benign obstruction or malignant obstruction. Benign obstruction, it is useful in the management of stones in the bile duct, strictures in the bile duct, extrinsic compression, and post-operative bile duct injuries. If you come to the malignant obstruction, its role is not therapeutic, it is palliative. Therapeutic role is for surgery. Palliation, definitely it has a role. It helps the patient in preventing from jaundice, itching because of the obstruction, and cholangitis. So with that, keeping in mind the complications of ERCP. If it is judiciously applied, it is a useful procedure for benign conditions and a good palliative tool for malignant conditions. So that brings to the end of my presentation. Thank you very much.
Well, thank you very much, Dr. Makunda. Another excellent lecture. I leave the rest and the questions and everything else to Dr. Abdul Qadir. Dr. Abdul Qadir, please.
Okay. Thank you very much, Dr. Matouk. Can you hear me?
Yeah, you are okay, Dr. Abdul Qadir.
Okay. Thank you very much, Dr. Matouk. Thank you, Dr. Samer, for the excellent presentation, percutaneous endoscopy, gastrostomy, and Dr. Makunda about the ERCP and extrahepatic biliary obstruction. I would like to thank both of you for the excellent presentation, despite it's very technical, but both of you made the technical issues for the gastroenterology so easy. So I think myself and the rest of the audience, now they all becomes semi-gastroenterologist. Thank you very much for that. I would like to open the question now for the audience. And I have sent a message during the presentation to write the question on the chat. I've received a question from Dr. Aktham. I think it's for Dr. Samer. Is the CT scan guided gastrostomy is better when you compare it with the contraindication and complications?
Yeah, well, CT guidance for the surgeon to do it, well, it is a possibility. I remember also that during my practice or during my study in medicine, we had a very clever professor of anesthesia who used to use a light through a nasogastric tube. He inserted a light, strong light, through a nasogastric tube to the stomach, and he did the incision by himself over the abdominal wall. And of course, he identified the place where he's going to do his incision by the trans-illumination done by the light through the nasogastric tube. Oh, sorry, yes, the nasogastric tube. So it is possible. There are different methods. Radiology, you can use fluoroscopy, you can use the CT, you can do it directly if you are a surgeon. Yeah, it is a possibility. If you identify the anatomies, the idea is just to avoid to penetrate or puncture another organ.
Okay. Thank you very much, Dr. Samer. I've got a message here from Dr. Nabil. Thanks for the nice presentation, but there is no question. Any other question? Anyone want to ask directly or to write on the chat? Okay, if not, I'll ask Dr. Samer about, you've mentioned in the contraindication for the PEG insertion, and I'm sure also for the same for the ERCP, about the coagulopathy and the thrombocytopenia. It's for both Dr. Samer and Dr. Makunda. When we're talking about the coagulopathy or the INR, is the INR the standard and the platelets count? What is the cutoff below which you want to go ahead for this procedure?
Yeah, hello. Yeah, I can start with that if you don't mind. So
okay.
Yeah, well, the idea is we need to avoid bleeding. So for the PEG tube insertion, if the patient is using anti-aggregants like aspirin, for example, or Plavix, we need to stop the aspirin 3 to 4 days, with regardless if he has normal INR or normal thrombocyte platelets, because the bleeding time in this case will be increased. And if it is Plavix, we need to stop it for 7 days. If the patient, of course, we do check all these things, the medications. If the patient is on any kind of medications, we check also the platelets. Platelets, if they are less than 80, or let's say 70, I can accept sometimes. Yeah, so in this case 70,000, sorry, yeah, so not yeah, so in this case I still can go for the procedure with precautions. If it is less than that, some patients they have like 40,000, 30,000, the risk of bleeding is high, so we can give platelets earlier before the procedure, like 3 to 4 hours before the procedure. And of course, INR, the cut point for me is 1.8 if the patient is on warfarin, let's say. So of course, the warfarin should be suspended, should be stopped until the INR is 1.6, 1.7. I can do the procedure with that for the PEG tube, of course. And if there is a patient who is on heparin, 4 hours suspension of the heparin, and then we can resume it later if we are sure that there is no further bleeding. Enoxaparin or low molecular heparin for 12 hours before the procedure. We can do it safely, and then we can restart it 12 hours after the procedure or 24 hours after the procedure.
Thank you, Dr. Samer. Dr. Mukunda, is the same for the ERCP?
Yeah, it's basically, can you hear me? Yeah. Yeah, it's basically the same. Yeah, 70,000 cutoff for platelet count is across the board actually for most of the surgeries as well as procedures, including PEG, ERCP. The problem in ERCP is sphincterotomy. When we cut the sphincter, there is a risk of bleeding. So as Dr. Samar said, aspirin and Plavix, we need to stop actually. We are more worried about Plavix actually. Plavix is more dangerous and it should be stopped for 7 days, definitely before the procedure. And if the patient is on warfarin, I would like to switch over from warfarin to low molecular weight heparin because you can handle it easily. Like 8 to 12 hours, heparin is 8 hours and low molecular weight heparin 12 hours. If you give the low molecular weight heparin, you can control you skip the dose and you can proceed with the procedure. But yeah, definitely, if the platelet counts are lower than 70,000, you will have to correct it. And INR high, yeah, it's a risk factor for bleeding. And I will prefer to change to a low molecular weight heparin if the patient is having atrial fibrillation or conditions like that where the cardiologist is not willing to stop it. And I would like to take the primary caregiver also into confidence before proceeding for the procedure, the involvement of the cardiologist and the neurologist, if they are also equal shares in the caregiving actually. And we'll take their opinion also before stopping.
Thank you very much, Dr. Mukunda.
Yeah.
There is another question from Dr. Aktham to Dr. Mukunda. Could you please clarify the difference between the sphenectomy and sphenectoplasty?
Sphincteroplasty, yeah. This is a good question actually. Basically, sphincterotomy, especially in patients with coagulopathy, we are a bit afraid to do. Actually, nowadays, the advantage of sphincterotomy, the complication of sphincterotomy is mainly bleeding. While sphincteroplasty, basically you use a balloon and dilate the opening of the sphincter of OD, but it has more chances of pancreatitis. So pancreatitis is more common with sphincteroplasty, while sphincterotomy has less chance of pancreatitis, but more chance of bleeding. So what many people nowadays do in patients with high risk for bleeding is that they create a small cut and increase the size of the opening with a sphincteroplasty to get advantage of both the scenarios.
Thank you very much, Dr. Mukunda.
Yeah.
There is a question from Dr. Matuk to Dr. Samer. How often do we need to change the PEG tube for LTC patient, long-term care patients?
Well, this is individual. If there is a proper care of the tube and it is cleaned properly all the time, so it can just continue using it until it gets like damaged or blocked or whatever, until there is a reason to remove it. But we usually do it like at least once per year.
Okay, Dr. Samer, because I was going to ask the same question, but not for the PEG, for the Mickey button. How often do we need to change this? Is it Yearly as well?
Well, this is the same, but usually the Mickey ones, we use it in children. And in this case, if the child is growing, you might need to change also the size, because the abdominal wall, or the size, or the length between the gastric wall and the abdominal wall increases. So yeah, sometimes we need to do it like more frequent in children, but yes, every 1 year, I would say, unless there is another reason, or there is obstruction, there is a problem with the peg tube itself.
Okay, thank you very much, Dr. Samer. There is a question from Dr. Safa Muhammad. Can peg tube cause obstructive jaundice? And if there is peg tube abscess, does it warrant removal and replacement?
Well, the first question, if it can cause obstructive jaundice, it shouldn't, because we are working with the stomach, and the papilla, or the bile duct system is in the duodenum. So it doesn't. So it has nothing to do with that, unless there is, let's say, like a hepatomegaly, and there was like a complication with the insertion, and this appears from the beginning, that there was like a wrong penetration to the let's say to the liver, and there was like damage to the bile ducts or something. So I didn't see this in practice, honestly. But no, it doesn't. It has different, it is inserted in the stomach, which is far from the bile ducts. So it shouldn't cause any kind of obstructive jaundice. The second question, if there is an abscess at the stomy site, this is what I understood, right?
Yeah.
At the stomy site. So if this abscess is treatable, we should treat it locally, of course, yeah, and if possible, we need to close it and to reinsert another one in another place to give a possibility for it, to give the chance for the healing. It depends how big is that and how bad is that. Every case is evaluated individually. But if there's a big infection, we prefer in this case just to clean, or to treat the place which is like damaged, and we will go to a little bit, we reinsert a new one a little bit like few centimeters far from the first insertion.
Thank you very much, Dr. Samer. Any other question? There isn't any question here in the chat. And anyone want to ask directly to Dr. Samer or Dr. Makunda? Okay, I'll ask Dr. Samer again. Dr. Samer, as far as I know, one of the complications of the peg insertion can aggravate and worsen the reflux. Is this true?
Well, I wouldn't say that it is due to the peg tube insertion. Usually the patients, those are like on bedridden, and they have different problems. And the stomach is a live organ. It is not only secreting its juice to digest, but it is usually moving organ, and it to push the food down to the bowel. So this movement is a kind of limited by fixating the wall to the gastric wall to the abdominal wall. So I would say yes, the possibility of reflux is there. But on the other hand, it depends on the place of insertion. The best place of insertion is at the lower part of the stomach. So if this insertion was a little bit higher, the possibility of reflux is high. But if you remember in my lecture, I have mentioned that patients who are bedridden, they have recurrent aspiration pneumonia. So that's why we do insert a peg tube to avoid that. So it should help directing the food down to the bowel if the insertion is in the lower part of the stomach, and of course if we put the patient in on his right side more frequent after feeding, so that we will enhance the movement of the food to the small bowel, to the duodenum.
Okay, so for example, if you have a patient with severe reflux, do you do the gastrostomy with the fundoplications, or even with the gastrostomy will be okay?
Well, fundoplication is a surgical intervention. As
Yeah.
gastroenterologists, we do not do it. This is if the surgeon decides to do it in a bedridden patient or long term. This is like, I think he won't do it during this stage. So our best care now, or what our best interest is, to feed the patient at this stage. So the gastro or the GERD or reflux problem is not a big deal for us during this stage, and no, it is not a contraindication. We can still insert the PEG tube, and no problem with that.
Okay, thank you very much. There is a question from Dr. Matuk to Dr. Mukunda. Is there a place for an urgent ERCP? And if yes, what are the indications for an urgent ERCP?
Yeah, definitely ERCP is mostly in bile stones, as I said, cholelithiasis with cholangitis. You require an urgent ERCP within 24 hours. The bile duct stones obstructing the bile duct, causing infection is a indication. Then gallstone pancreatitis of moderate severity associated with bile duct stones present, you have to do ERCP. If the stones are passed out, no need for urgent ERCP in that scenario. So these are the two main indications where you require an urgent ERCP. And of course,
I know the, thank you, Dr. Mukunda. Yeah. I know the philosophy behind the question from Dr. Matuk. You want to be sure that one of you on call every night. Right.
Dr. Abdul Qadir, I didn't mean that.
Any more questions? Okay, I have one more question to Dr. Sam about the PEG insertion. When would you start the feeding after inserting the PEG?
Well, 6 hours after the procedure, if there is no leakage, no signs of infection, I usually start with giving small boluses of water first to confirm that there is no leakage. Other colleagues, they prefer to wait until the next day to make sure that it has healed properly. But I believe that it is fine to start earlier. So yes, at the beginning, 6 hours after the procedure, we start with small boluses of water. If there is no bleeding, no signs of leakage, we can start feeding immediately or on the next day, it doesn't matter.
Thank you very much, Dr. Samer. Dr. Safa, I think, want to ask a question herself. Yes, Dr. Safa.
Hello, hi, doctors. Thank you for the very informative presentation. Actually, I'm asking about one of our current patients we just received today. This patient have a PEG tube. It's actually why I asked for the obstructive jaundice, because the PEG tube, first time I see this position, the patient is obese and it's exactly in the epigastrium, so just very high and very central. And she came with obstructive jaundice and abscess around the PEG tube insertion site. So my question again is, because ultrasound done, there is no stone obstructing the CBT. So there is any possibility of the extension of the abscess and causing this obstructive jaundice, as well as if there is such abscess resulting in sepsis, can we totally remove it, and when should consider replacing this PEG tube?
Well, as I mentioned, usually the PEG tube insertion has nothing to do with obstructive jaundice. So the question first, whether it is a jaundice or obstructive jaundice. How did you identify that it is obstructive? Did we do MRCP, for example? Did we do, have we got the obstructive enzymes elevated? Is it the direct bilirubin which is elevated? So we need to find out. We need to find, I believe it might be something else which is causing the jaundice. maybe a medication could be something toxic. I'm not sure. So we need to identify. We need more details to see if what is going on. So let's say that the PEG tube has a reason for this, or a cause or etiology with that. So let's say if it has moved from its place and it is not working properly, and it passed to the duodenum and blocked the papilla, which is not possible, I believe, because the small bowel will move it down. And in this case, the PEG tube is not going to work. So this is like a scenario we have just created, or just trying to find out what would cause that. But no, if the PEG tube is working properly, so it shouldn't cause that. We need to do more investigations to identify what would be the reason of the jaundice and whether it is a real obstructive jaundice or not. Abscess should be treated. Yes, PEG tube, if you feel that the abscess is really big, and the PEG tube should be stopped or discontinued or removed. Another one should be inserted or go, like, let's say, for a few days parenteral nutrition, and then later on we can reinsert a new one.
Yeah, I think Dr. Samer, yes, Dr. Safa, I think the patient just moved in today, admitted today, and the patient was admitted from another healthcare facility in the city for obviously investigating this problem. So I'm sure Dr. Safa will be arranging the necessary consultations from the multidisciplinary team, gastroenterologists and internists, intensivists, and the rest of it. I'm sure Dr. Mukunda or Dr. Muad will be the first on the list to see this patient.
Okay. Dr. Safa, is your question answered?
Yes, doctor. Thank you so much.
Thank you very much. Any other questions? Okay. Sound looks no more questions. Okay, thank you very much. I would like to thank our audience for coming and attending this excellent session. I would like to thank our speakers, Dr. Samer El-Assala and Dr. Mukunda, for their excellent presentation about the percutaneous endoscopy, gastrostomy, and ERCP in extrahepatic biliary obstruction. As I said, despite this, the presentation were technical, but you made it so simple. So thank you very much for your presentation and for your time. At the same time, I would like to thank our CME committees, Hassan, for all the work you do, Hannah and Dilani. Thank you very much. Excellent preparation. And thank you also for the interactive sessions between the speakers and the audience. And inshallah, we will meet again in 2 weeks' time. Sorry, what is the next topic, Hassan? Hassan?
It will be ENT, doctor.
ENT, okay.
ENT,
Thank you very much. So inshallah, we'll see you again in 2 weeks' time. Thank you very much and have a nice evening.
Thank you.
Bye.
Bye-bye. Good night.
Bye-bye.
Good night.
Good night.
Good night.
Good night.